Share screen next to scare.
Yeah.
Got it. Thank you.
Welcome. So just to wind up last session, the step-by-step approach to tear trough. So whenever you are doing a tear trough, this is the approach. First of all, the first thing is mark the orbicularis retaining ligament. Second, mark the zygomaticocutaneous ligament. Third,
Yeah.
mark the malar mound and put a cross over it. That is a no-go zone. Mark the infraorbital artery, put a cross over it. That's a no-go zone. The remaining area you are free to, inject. Look for any pigment deposit or venous shadows, Then do the cheek pull-up test. If you do the cheek pull-up test, you pull the cheek on the zygomatic arch upwards. If there is slight improvement in the tear trough area after you pull the cheek, then that means you have to do cheek first.
Cheek means CK1, CK2.
Yeah, CK1, CK2. Then
Okay.
second is do the earbud test. Press in the anterior malar region with the earbud or with the finger. And if there is an improvement in the tear trough, that means you have to do the anterior malar region first.
That is CK3.
Yes. And
So,
once we're done with this, we can directly go to the tear trough.
Yeah. Okay. Yeah.
Right?
Thank you.
So, so now the MD codes for the 3-point tear trough reshape. So once we are clear that now, okay, in young patients, the cheek pull-up test is negative, the anterior malar compression is negative, directly tear trough can be addressed.
Yeah.
So the 3-point tear trough reshape. So can you see the screen?
I'm seeing it's all mixed up, but there's not a one slide. I'm seeing notes, duration, timer, page, and all these things like that.
Now is it visible?
There's the same page that's coming. The whole page. I can see the page, but
Just a second. Give me a second. Now is it fine?
yeah, now I can see.
Okay. So the 3-point tear trough reshape. So in this, the numbering of the points is such that the first point, like if it is TT1, that has to be addressed first. That is the sequence in which they are numbered. So it is TT1, TT2, and TT3. That means you have to inject 1 first, then 2, then 3.
Yeah.
Similarly, when CK1, CK2, CK3 means first do CK1, then CK2, then CK3.
Yeah.
So that is the order in which we have to inject. That is the numbering in the order. So TT1 is central infraorbital, TT2 is lateral, and TT3 is medial. So first area to be addressed, first region to be addressed is the central infraorbital, just beneath the mid-pupillary line. So in the TT1 area, you have to be careful about the infraorbital artery. And in TT3, you have to be aware of the angular artery and the vein. And consider avoiding deep injection with needles at the infraorbital foramen. And if ever you have to inject, it has to be from above. Protect the orbit and inject from above, never from below. Sometimes when you're injecting from below, you can actually feel the needle going inside the foramen. At times it happens.
So with the needle, how do you go from above? Cannula, I can understand.
It has to be like that. It has to be from like this, not like this.
Can you show again?
From above.
With the needle. Okay, above.
Above, not
Means
like
45 degree?
Yeah, 45 degrees. So that's how. Always protect the orbit from the non-injecting hand.
But here they're showing it injecting from below.
That is
What
for
do
the
you say?
purpose of taking picture. If they would have taken from above, then the photo would not have come. So this is to
Oh,
show the injection point.
okay.
So central infraorbital TT1, this lies just above CK3 point. Some people they think that it's an overlap of CK3 and TT1, but CK3 is a region. It is not one point, and TT1
Okay.
is 1 point.
Okay. Yeah.
Okay. So minimum is 0.1 to 0.3. Product of choice is Volbella. Device is
Yeah.
preferably needle or a cannula. Delivery is micro aliquots, like very small, not even a bolus. So here at this point, aspiration is mandatory. I don't know how much you agree with the point of aspiration, because when it comes to aspiration, different doctors have their different opinions, and usually it's the dermatologists and the non-surgical field people who prefer injecting. Usually surgeons, they don't believe in aspirating. I don't know why. That's what I've observed. So it's up to you. But otherwise, they say it's like good to aspirate
Yeah.
for 10 to 12 seconds. Not just aspirate for 1 or 2 seconds. Aspirate, wait for 10 to 12 seconds, and then start injecting.
Yeah.
So that's how you do TT1. Protect the orbit from the non-injecting hand. With a cannula, with a needle. So actually, the cannula that is shown in this is not the entry point. The entry point is little lateral.
Yeah. Why are they showing diagrams like this? I'm just wondering.
Because that
The
is the
angle is,
way they can take a picture of it. I don't know. You can actually, from here also you can inject, but it's not very practical, because even with micro cannula, this small
yeah.
distance, it is how you can maneuver your cannula with ease. So you have to find a point for yourself from wherever, you can maneuver your cannula with ease.
Yeah.
So 25 gauge micro cannula is best for under eyes and all those areas. Then lateral infraorbital is TT2. Again, product of choice is Juvederm volbella, 0.1 to 0.3 micro aliquots. And alert zone is, obviously infraorbital foramen, but it's quite far from this TT3 point. It improves the infraorbital area. So this point is required, TT2 point is required if the tear trough goes up till the lateral canthus. If it is just till the mid pupillary line, then TT3 point is not required.
So, what is the exact location of TT2 point?
TT2 is beneath the lateral canthus.
Oh.
That's how you do lateral. These cannula pictures are not good. Please don't go through the needle is fine, but this is not how you do TT2 with a cannula.
Yeah.
Then medial infraorbital TT3. It is very rarely required, but if at all it has to be done, be wary of the angular artery, dorsal nasal artery, all those arteries lie in this zone only. Usually what I do is we inject TT2, and from there you massage medially instead of injecting.
TT1.
Yeah.
You mean TT1?
Slightly medial to TT1 and then massage medially. So you can displace the product over there. If you're not confident initially injecting with a needle at TT3 point. Again, product of choice is same, Volbella, 0.1 is recommended volume. Device could be needle or cannula, micro aliquots.
Yes.
So when you're doing only tear trough, 0.3 this side, each side is more than sufficient. Usually 0.3 is required when the entire expanse is covering, like it's the tear trough hollowness is starting from medial canthus and continuing till lateral canthus. Otherwise, 0.2 each side is more than sufficient with volbella.
So it is 0.1 in T2, 0.21 in T1, 0.1.
Yes, yes,
Like
yes.
that. 0.1 on each spot.
Yeah, on each point, 0.1. Now with volbella, you can be a little superficial, but with volift, it has to be always on the bone. The benefits of using volbella over any other product is that volbella gives a pinkish tinge, The chances of tyndall are less as compared to other products with volbella. If you are planning to inject superficially, very superficially for hydration, it's always better to use volbella rather than Ultra Plus XC or any other product, because other products are more prone to giving a tyndall effect. Volbella doesn't. Volbella gives a pinkish tinge. So that's how. Always protect the orbit with the non-injecting hand. So this was about the zones. Now periorbital edema. I don't have the slides for this, but I'll just go through this thing. Like periorbital edema, it is one of the most common complications after tear trough. So we can categorize into non-inflammatory and inflammatory. Most commonly is non-inflammatory. Now there can be 3 causes for the periorbital edema. It could be product related, it could be patient related, and it could be procedure related. So when we talk about product related, there are 2 causes. It could, because first thing, the product is hydrophilic, that is, it absorbs water. So the products vary, like Ultra Plus XC absorbs the maximum amount, volume absorbs the minimum amount, volbella also absorbs, but it is in between these two. So the amount of the fluid the product is attracting, it varies from product to product and company to company, brand to brand. So products which are better at creating volume, they tend to attract more moisture, because that is how the filler is assigned to create volume. It doesn't create volume per se by its own existence. It is creating volume by hydration. So if it is more hydrating, then it will create more volume. So that is why minimum product is required at each point. Third is poor integration of the product. Products which fail to integrate quickly are liable to move from the intended site over days and weeks and cause aesthetic upset. Now, filler migration is another topic of discussion for another video, but I'll just mention 1-2 points in this, that a soft product is more, prone to getting displaced, because first of all, we mentioned that the muscle is very strong muscle, So if there is someone who is doing weightlifting or strength training, they are mostly closing their force closing their eyes most often, right? So in them, there is a tendency for displacement. Secondly, when there's seasonal allergies, people keep rubbing their eyes. So in that case also, there is chance for filler displacement. So if you find any of these things in a person, you have to make them consciously aware about these things, because they won't know.
So for under eye, the best filler is volbella, I suppose.
Volbella is the best. Yeah, volbella or volift. First choice is volbella.
Yeah, I remember I had a patient, we gave under eye and there's a swelling, periorbital swelling.
Yes.
It became very difficult to handle that patient. Ultimately, they wanted the refund back and we gave the money back and things like that.
Yeah. So it is
Became
very
a big problem.
Yeah. So there are multiple causes of periorbital edema. So I've mentioned product related causes. Then second is patient related, like they have tendency of fluid retention, puffiness around the face, which may be worsened by addition of fillers. And sometimes anatomically, there are ligaments and fluid drainage and all, because of the lymphatic obstruction to lymphatic drainage. there are chances of fluid retention in that area. So in cases where lymphatic drainage is obstructed, you will always find small degree of malar mound. There will be a festoon present over there. Now
So in
procedure.
such cases, we just reduce the amount of filler or anything else.
Be very, you can use very minimal amount, like 0.1 is sufficient for them. Don't, and also filler patient and under tear trough patient, if he is happy on the table in the clinic at the time of the procedure, that means you are going to end up in trouble. Because my first complication was this periorbital edema, because I had injected someone in Bhopal, and I had flown, and after 2 days there was a big hue and cry, because the whole
Yeah,
area swollen. And why did it happen? Because she's like, doctor, I have to go there today, I have a function coming up and all that. So it's still seen. So because I corrected it, completely corrected it, that's why there was a problem. I should have always under corrected. So never get into those small requests. Never.
I can understand that because I have undergone the same thing.
Yeah.
And fine. With 0.1 ml, we don't face this problem.
No, we wouldn't.
Okay. Yeah,
So,
fine.
again, procedure related, maybe first of all, clinician related, excess volume deposited at the site. And second, which is a very something which cannot be dealt with easily, is the superficial placement or placement behind the orbital septum. That this is a most complicated, which cannot be handled even by hyaluronidase also. So that is why they say stay away from the orbit, never above the ORL. So how do you manage?
Yeah.
First of all, massage, you can give firmly compress the areas of fullness and massage the periorbital area. Use a cream or a lubricant to do the massage. Give them arnica cream. They can do some icing, regular massage by the patient at the home. Wait and watch. And in the end, if it is still problematic, then you can use hyaluronidase, but which is not usually advisable, because swelling sometimes it goes over with time is the best healer for periorbital swelling. But
Okay.
there is a few days of disturbance do exist, but then it goes off.
In case you need to use hyaluronidase, what concentration do you use?
That I'll give an chart. This thing, a chart is there. You can use that chart according to the VO or whatever is expected. Usually 0.1. After full dilution, 0.1 in this area is more than sufficient. Then few individuals say that, for some doctor was saying that natural hyaluronic acid also gets depleted in that area. Yes, it does get depleted, but the body is making every 24 hours is replaced. So it's not a very big problem. So this was about periorbital edema. Second most common concern that people, the complication that happens is the bruise. So
Yeah.
few points that you can help is, first of all, how to reduce the bruising from injections is like seek out any risk factors like alcohol, heat, exercise, medication, and do not stop medication prescribed for secondary prevention of cardiovascular disease. But otherwise, if they are taking multivitamins and all, they can be always, reduced for a few days. Consider what you can do to avoid the major vessels. Obviously, mark the no-go zones before itself. Now, after injecting, if you give enough time for cold compression and massage. So if you have seen, you will get to know whether the area is going to bruise or not, because while injecting, you develop, there is oozing of blood. So the moment there is oozing of blood, there's going to be a bruise. So at that point, stop injecting, compress that area, wait for 5-10 minutes, do icing for 5-10 minutes. If you do this, the bruise is not going to even develop. and then you resume your injecting afterwards. So what we do usually, we ignore that point and then keep on injecting. If you feel that there is some oozing of the blood and a bruise can develop, stop injecting. Attend to that area, wait, give compression over that area for 5 minutes, and then do some icing, and then do the rest of the procedure. So if this protocol is followed, then the bruise develop, either it will not develop, or if at all it develops, it will be very minimal.
So you compress it and then do the icing?
Yeah, just compress it for few seconds, because what happens when you withdraw the needle and then there is oozing and you just leave it like that, so internal oozing continues for quite some time.
Yeah.
Right. So if you stop injecting and compress it immediately, you are reducing the amount of oozing out of blood.
Yeah.
So wait for 5 minutes and then you do your rest of the procedure. And
we compress for 3 minutes or 4 minutes and then do icing after that.
Yes. And once this is done, then you complete the rest of the procedure. In this way, the bruise that develops will be minimal, or maybe it doesn't. And sometimes the veins can be seen. So wherever the veins are seen, do not make your injection points if the veins are very quite visible. So because the blood is pooled when lying down, sit the patient up for injection so the blood drains from their head and veins, etc. Give them arnica cream or arnica tablets to apply on that area. And now you can increase the needle control in various ways. Basically a bruise is there because a vessel has been ruptured or punctured with the needle. So a good needle control, they say that it starts with your feet. So whenever you're injecting, your injecting angle should be a good angle. You have to be comfortable with your body while you're injecting. So once that needle control is good and you are observing and seeing and watching and avoiding all the vascular shadows, the bruise can be minimized. So these are the various ways in which you can avoid the bruise.
Yeah.
And once it has formed, then obviously what you can do is that give them arnica cream or tablets and tell them to keep icing and all.
Is there any vitamin K cream available?
Yeah, it is. I think it is available.
Which
I'm
one?
not prescribed. I'll just find out. I'll let you know. Vitamin K creams are available.
Okay.
There are tablets also which contains a pineapple enzyme. Some people give that also. I've never done usually.
Yeah.
So this was about the periorbital. So I think we've done all the points in the periorbital. If you have anything, any question, we can discuss.
Yeah, I went for a training with Allergan in this periorbital region, mid-face. So periorbital was a part of it. So there it was, taught first they fill the medial cheek fat pad, then they work on the SOOF, then they work to the T1, T2, T3. So they work at 3 different points, First, they would work on the medial cheek fat pad. For that, they would use voluma there.
Yeah.
Then they would come to SOOF, and SOOF, they said you have a choice whether to use voluma or volbella. And then you come to T1, T2, T3. Then you work there giving volbella. So do you work like that?
Yeah, that's why I said medial cheek fat pad is CK3.
Yeah.
CK3 is not a point, it's a region. It's an area.
Yeah.
Again, CK1 is not one point, it is a region. Right?
Yeah.
So that's what I said. First do cheek. If the cheek pull-up test is positive, first do cheek. If the earbud test or finger compression test is positive in the anterior malar region, then do the anterior, medial cheek fat pad. And SOOF is exactly the point that is CK2.
CK2.
Not CK2, TT1. SOOF is the point
TT1.
that corresponds to TT1.
TT1. TT1. So I mean to say is that we are filling the cheek fat pads by voluma using CK3 and points around CK3 basically.
Yeah.
And the SOOF is TT1, TT2, and TT3.
Yes.
They're following the SOOF.
Yes.
So SOOF we are using volbella. So we're using two different products, Voluma and Volbella.
Yes.
Okay.
And in Trough, you can use Volift also.
Yeah.
So what I do,
they're two different.
Yeah, two different products. So now the practical, how to be practical about, because obviously if person is coming and they are not able to buy 2 syringes, or maybe Voluma and Volbella combination is not possible, then what you do, you use for Volift entirely. In CK3 also Volift, and then in Trough also Volift. So that way 1 syringe will be sufficient.
In that case, how much do you need when you combine medial cheek fat with
So
T1,
medial
T2,
cheek,
T3?
maybe, before doing medial cheek, you will do a little bit of lateral cheek also. So if 2 ml
Yeah.
is possible for them to buy, then do lateral cheek, medial cheek, and then the Trough. If 2 ml is not possible, you have only 1 syringe, then do medial cheek and Trough only. So you have 0.5 for this size and 0.5 for this side. You can distribute, 0.3 and 0.2, 0.3, 0.2.
0.3 in the medial cheek.
Yes.
Again, in the medial cheek, we'll do fanning.
You can, depend. It all depends.
We were taught to do the fanning in the medial cheek.
Yeah. So if the product is, you have only 0.5 ml per side, then if you do fanning, then cannula takes a lot of product. So it is difficult to, if you start using cannula, the entire 0.5 you can inject easily, So the benefit of needle is that you can control the amount of product you're injecting. With cannula, it's very easy to put in the product without it being, obvious.
So how do you put in the CK3 or the medial cheek pad? How do you put the needle?
With the needle. Yeah, directly on the bone.
On the bone. Which point do you select exactly? Deepest depression or deepest recession or?
Okay. So you first, there's an intraorbital foramen, infraorbital, just lateral to the infraorbital foramen, and slightly beneath it. That is a point where you can inject the CK3.
Yeah.
You give point.
Yeah, because the medial cheek pad is more like almost like an inverted triangle area.
Yes, yes. So the base is up. Yeah. So this is the
base is up. That's right. So when we are injecting at one point, then we have to massage and spread it, I think.
Yes. So when you inject first, you choose a point lateral to the infraorbital foramen, just beneath the mid-pupillary line, slightly beneath the orbital rim.
Yeah.
That is the point you inject. After you inject, you press it and then you can massage it.
To spread it.
Yes.
Yeah. Otherwise, if you're using the cannula, then we do the fanning technique.
Yeah, you can do the fanning technique.
In that also, we are going deep on the bone.
Cannula, we are going deep. That gritty feeling,
on the bone.
Tip of the cannula should feel that gritty feeling of sliding.
So medial cheek also go on the bone.
Yes.
For the medial cheek.
If you are superficial in the medial cheek area, then what will happen when the person smiles? When they smile, there will be a bulge seen. If you are superficial, that bulge will be seen.
So we'll have to be deep in the medial cheek also.
Yes.
Yeah. And then, we have to be born on TT1, TT2, and T.
Yes.
Yeah. Fine. So normally TT2 is not needed.
Usually it is not required.
TT1 and TT3 are needed. TT1 and TT3 are needed.
TT1 and TT3 more in many cases. Usually TT2 is not required. If at all it does, then you can address it.
But mostly TT1 and TT3.
Yeah.
Okay. And for TT3, you're saying you can inject little lateral or little medial to TT1 and then massage it towards.
Massage it medially like this.
Medially. Yeah.
And avoid the BD syringe. Most of the doctors, they feel that, BD syringe, Volbella, it's easier to do, but it can puncture the veins. This area is very